I'm Lee Doherty-Biddison.
And I'm Carolyn Kamsty-Fowler, and we're your co-hosts for the Johns Hopkins Office of Wellbeing's podcast, Vital Conversations, Influencing Workplace Wellbeing in Healthcare.
We spend a lot of time thinking about how to influence workplace well-being in healthcare, and we're excited to share what we're learning.
Thank you for joining us.
Hello and welcome. I'm Lee Doherty-Biddison, your host for the Vital Conversations podcast. It's a pleasure to have with me today Dr. Steve Kravet. Steve is the president of Johns Hopkins Community Physicians. He is a clinical professor of medicine and holds the L. Douglas Lee and Barbara Levinson Lee Professorship in Clinical Medicine. Steve, so great to have you with us today.
Thanks, Lee. Great pleasure.
I am excited, really thrilled to have the opportunity to talk with Steve about some of the amazing successes that Johns Hopkins Community Physicians, or JHCP, has had in really focusing on enhancing and improving the well-being of their clinical providers. It's been an amazing journey. I've got many friends in the JHCP community and have been really thrilled to watch this develop over time and really see JHCP stand out as a leader in this space, both within our organization and nationally. So Steve, maybe just in laying the groundwork, tell us a little bit about the history of Johns Hopkins Community Physicians. Where did it start? What was the purpose, the goals?
Yeah, thanks, Lee. Actually, it's very interesting. The history of JHCP dates back earlier than Johns Hopkins itself, and
Nice.
it has its roots in the military. There was a military hospital. I believe it was the hospital that was down near Fort McHenry. If you ever visit Fort McHenry, you see pictures about the old military hospital that was originally there to take care of the merchant marines. And then that became a U.S. Public Health Service hospital when it was rebuilt near the Hopkins Homewood campus, Wyman Park.
Uh-huh.
It existed for a few decades until the early days of the Reagan administration, 1982, when all of the U.S. Public Health Service hospitals around the country were closed for cost-saving measures, except for six. Six of them, instead of closing, were taken over by private organizations. And the organization that took over that hospital was called the Wyman Park Medical Associates. So it existed for a few years. Hopkins ultimately acquired the Wyman Park Medical Associates. And so it was the military treatment facility, and then a whole series of outpatient practices that at the time were linked to the military, to where military bases existed around this region. There was also a series of HMOs at the time that Hopkins had been involved in starting. Those organizations kind of merged, and the organization that was formerly called the Johns Hopkins Medical Services Corporation began, and that was in the early 1990s. So the organization existed largely as a primary care organization, managing practices in the greater Baltimore area, and then these satellite practices all over the state that were near military bases, which is just so odd. In the early 2000s, when Bayview's primary care network merged with the existing Medical Service Corporation, they created a large organization with some consolidation of practices geographically and took the name Johns Hopkins Community Physicians. That was around 2003. In 2010, when Suburban joined the Johns Hopkins family, they had 60 physicians and advanced practice providers, largely specialists. So surgical specialists, medical specialists, hospitalists. And the decision was made at that time to bring them into JHCP because they were community-based and JHCP was community-based. And that was the moment when JHCP became really a multi-specialty organization. Prior to that, we were largely pediatrics, adult medicine, and OBGYN. And then when we took on the specialty groups, it opened the doors to JHCP functioning more as a multi-specialty practice and building over larger geographies. So of course, with Suburban and Sibley then joining the health system, there was a need to grow in the National Capital Region. So that has really been the focus of growth over the past 15 to 16 years. We went from 18 practices now to over 50. We went from 150 providers to over 700. We went from about about 500,000 visits a year to this year for the first time over 1 million visits a year. So yeah, we are, it's a force to be reckoned with.
It is a force to be reckoned with, and it's no, sometimes that rapid growth can be really challenging, but it feels like, at least from, the external observer that, JHCP has kind of taken it all in stride. What are some of the challenges through that growth process?
Whenever I hear somebody say that, which is so nice to hear, Lee, because you always have pride in an organization that you're trying to lead. I don't know. I kind of hear that, but it never feels that way because that's so hard. And of all the things that I worry about and our leadership teams worry about, it's really the people at the front lines, who are trying to deliver care in more and more challenging environments. So yeah, I mean, there's lots of challenges from a business perspective around, growing an organization. But throughout all of that, I don't think any of us have ever stopped worrying about what it's like to wake up every day and provide, community-based care, throughout, a broad geography. But, the business challenges are, how do you keep people connected to the mission? How do you manage, a really broad geography? It's one thing to be able to be a leadership team where you can walk through the hospital, hall by hall and, meet with people. But when you have a widely distributed geographic organization, it's just that much harder to do that. It's hard to be present.
Absolutely.
The other thing that's hard is that, ambulatory medicine is, it's fast paced. You can't really take the time to step away from the patients to have engaging conversations. And so that part of it's been hard. It's again a little bit different when you're in a hospital or a non-clinical setting. People can step away from what they're doing, but you can't when you're a registration person really step away from the line of people standing in front of you to have a conversation with the president or the vice president when they come to visit.
Exactly.
So, that part of it's been a challenge. Finances are always a challenge. I think one of the things that Johns Hopkins Health System has felt about JHCP is we've been good stewards of finances. We benchmark, how much we invest in infrastructure, and we've always benchmarked well. And so I think that's given us the latitude, that when we ask for something, we've been able to get it. But that's always a challenge. And I think the greatest challenges over the past few years have really been linked to well-being. Which is linked to workplace safety, including since the pandemic, just how toxic the environment's been. Patients are struggling. They're at home struggling in their worlds, and it's not uncommon that they take it out on somebody who answers the phone or on, what seemingly is a small transactional issue that just triggers. And our staff are often, stuck's not the right word, but, are faced with managing through some of those challenges, and day in and day out, that takes its toll. So I think that's probably, the greatest challenge we've had over the past few years.
Can you say a little bit more about you were commenting on the fact that that stress and the well-being challenges really ramped up through the pandemic. Were there, and obviously, and you've given some great examples, were there specific components of helping the teams stay connected that were impacted during that time as well? Sometimes I think about, part of what helps us in healthcare to stay attached to the mission is to stay connected as a community. And at least I know in my own life, with more remote work and those types of things, which is supposed to help, right? It gives me more flexibility. Sometimes actually impacts these other pieces that sort of has a paradoxical impact.
Yeah, it's interesting. And it's something that I think a lot about. Some of the central services, are easier to become remote. And, for example, our corporate headquarters in JHCP is up at Mount Washington. And when we first moved into this space, we had about 30,000 square feet, about 100 people here on any given day. And, instantly in March of 2020, when the pandemic hit, we had 5 people here on any given day. We made the decision to downsize and try to make the most of our space, but a lot of our central teams are able to work remotely, which has been, a blessing and a curse. I think our leaders who lead central teams will tell you that even though people say that they love the flexibility of being able to work remotely, there's something missing in their
Right.
ability to remain connected. So they try to come in, the central teams on a regular basis, once or twice a month, to all be together. But I think that that's been a struggle. At the same time, our practices have never stopped seeing patients, in person. And our
Right.
frontline staff have always had to come in and take care of patients, just like hospital-based workers. I mean, the hospitals don't close, the practices don't close. And when the rest of the world is managing remotely, sometimes kids are off school or whatever the case is, that just exacerbated some of the tensions of trying to manage your life outside of work and then coming in here and trying to put all that aside and, be a source of comfort and compassion for patients who are seeing us every day. So I do think that the hybrid, environment and trying to manage how things work in the offices and at home has been a challenge for sure. The other thing that I didn't mention before that has been a challenge is, and partly it's a consequence of the pandemic, is the explosion in technology and data flow.
Yeah.
Uh, and as you know, in primary care in particular, it's just exploded the amount of data that we're being asked to manage and expected to manage. And heaven forbid you miss a piece of data that was in the cloud somewhere that could have impacted a patient. You could estimate it could take hours to keep up with all the data that are flowing in and out. And so that it creates an emotional challenge for our physicians and advanced practice clinicians in particular. And then of course the workflows that go into managing that have created stresses for the teams.
The what are the main ways you see that stress, or saw, because I hopefully we're over the hump, saw that stress manifest itself, especially at the front line?
I think that there was some turnover. There were folks who might have been, waning in their careers, who, through the pandemic said, emotionally, this is just too much for me. Some folks who had maybe some health-related issues felt uncomfortable, remaining in a face-to-face clinical environment. And so I think that there were some transitions. As is always the case, folks in the ambulatory world manage some of that work-life balance by trying to reduce their clinical FTE.
Yeah.
And so that happened for a little while. And of course, that creates organizational challenges. And we've had to address that, through some policies and protocols.
So now that's enough of what didn't go well or what was a challenge. This is my favorite part of the conversation, because I do know how the conversation ends, which is wonderful. Can you talk a little bit about some of the things that the team came together to do to intervene and try to sort of reverse some of these challenging experiences and have an impact for the front line?
Well, thanks for recognizing that and asking it. It is hard, and let me just digress for a second and say that engagement is something that has been so important to me as a leader and to our leadership team. Our human resources director Leslie Rohde and I have been partners in this, and I built a communications team. One of the first things I did when I came into the organization, because I think communication is really the lifeblood of any organization, and so. In our heyday, we had lots of fun communication. We did organization-wide, campaigns to bring out the engagement in an organization. Probably the best of which I was just talking about yesterday was the Y5, when we used to have the Gallup survey, and we had a campaign that we called Y5, like why would you rate JHCP a 5? And people would talk about that, and
Oh, nice.
yeah, that sense of sharing amongst each other why they felt engaged was, self-propagating. And I think that was really the heyday, probably the 2017, 2018 timeframe. And then things became more challenging, obviously, through the pandemic, and it's just been harder to overcome. But each practice has its own culture. And even though we are all part of JHCP, which is part of Johns Hopkins Medicine, I try to create a sense of why it's important to recognize how wonderful Johns Hopkins Medicine and how inspirational it is. But the practice culture really drives, I think, folks' day-to-day sense of engagement, knowing that they have the tools they need, feeling connected to the mission, listening to their opinions, And Hopkins is just a great place for opportunities to learn and grow. So we tried to lean into, whatever opportunities we had. Great examples that I think I'm really proud of our team, for driving forward. On the clinical side, our nurse, our chief nursing officer, Chris Rawlinson, has created amazing mentorship programs for emerging leaders, but we also developed externships for local medical assistant training programs so that we can bring people in and have a better idea of who the best of the best are to hire more effectively in the organization. And that is always helpful. So when you start off with people who are engaged and talented, it's much easier to maintain that. Other things have included a purposeful and supported leaning into joy in medicine. And so a lot of the work that you in joy in medicine and well-being was an inspiration for us. And we've had a couple of folks who stepped forward and said, look, I really want to help lead in this regard. So I've been fortunate enough to have, some of my professorship funds that I've been able to dedicate in small aliquots to some of our team members to help lead joy in medicine. We've had book clubs. We have almost monthly excursions that are open to everybody, physicians, advanced practice clinicians, staff. They're attended relatively sparsely, but for the people who attend, it means a lot. And then when we tell the stories and share the pictures of, what folks have done, I think that creates inspiration. Alice Lee, who's one of our office medical directors now at Columbia North, started something called Meraki, which was originally a magazine, like a printed compilation of art, whether it was photos or it was poems or sometimes music that had links that you can scan and listen to. That has perpetuated now for several years, and it's expanded to all of JHCP and is now available in digital form. And that's been such a source of joy for folks who are contributing, but also, really a sense of people accessing a different part of their brain, which is always an opportunity for joy. One of the things that has always struck me, and I've been so fortunate to have such a heterogeneous job, being an administrative leader, being a clinician, being a teacher, doing dissemination and research, that I think heterogeneity brings joy. Much harder to do that in a clinically oriented organization. Yeah. So we've tried to create opportunities for folks to step aside and do different things, whether it's participate in Johns Hopkins medicine courses, or to take a small supported job as a builder of templates, for Epic. All of those opportunities, when we spread them around, are little mini opportunities for joy as well. And so, just looking for different ways to add broad-brained experiences and time. Really time. We created a vision statement a number of years ago for JCP that I love. It says that we give our patients and our teams the time and attention needed to achieve their best health. So
I love that.
Time and attention are two resources that are really invaluable.
Absolutely.
Medicine is so fast-paced, and getting folks off that hamster wheel, our patients off the hamster wheel, so that we can give them the time and attention they need when they need it, we think is what success looks like. But our team members said, we can't do that unless we have time and attention. And so I know one of the elements that you have highlighted as being so successful in JHCP is the reduced face-to-face clinical time. That came about through just wonderful leadership at our health system level. Kevin Sowers, our health system president, asked us what we need. He knew and knows the importance of having a robust primary care network. If we could reduce our turnover, increase our retention, that's going to be the key to success for Johns Hopkins Medicine. And he asked us what we needed, and we said, we really need to reduce face-to-face clinical time because of all of this transaction that occurs. And so we calculated the investment required to give our frontline providers 4 more hours a week of non-face-to-face clinical time. And that has paid tremendous dividends because we've retained people. And when our physician recruiters are out there in the communities and they tell folks about how much protected time they have to manage their worlds, that's been a differentiator. People have come from far and near to work in our organization really because of that. So, smart people like Kevin Sowers making investments and us holding up our end of the deal, which is, making sure that when people are seeing patients, they're busy for 4 hours, has really been the recipe for success.
I just love that so much, Steve, as we think about, it's often in making the calculations like the administrative time thing that you're talking about, it's easy to focus just on the bottom line. And I love that the organization, both JHCP and the organization at large, were able to balance the conversation about the bottom line, which is important, with the broader need also of thriving clinicians who are able, because they are appropriately resourced and supported, and they're getting the time and attention that they need, like you said in the mission statement, to really do their job best for the long term. That it's just really such a beautiful example of seeing all that come together. And I, also just want to say that I think it's a brave thing as an organization to say we will invest this, right? There's lost revenue. That's, if you're seeing patients less, there is lost revenue. I was talking to a colleague who was looking at another one of your colleagues, Dr. Chaudhry, about this, and so neat to see that actually the lost revenue wasn't as much as it was thought to be in practicality. And so sometimes doing the right thing and thinking about the broader thriving of the organization actually doesn't cost as much as we sometimes think it might.
Yeah, well, I think that that's right, but it's hard work, Lee.
Yeah.
And the folks who are leading in the organization are really responsible for our success because they're leaning into being a nurturing organization, creating an enabling environment. I always say that people spend more waking time at work than they do at home, so they deserve to have an enabling environment. But in order to be able to do that, there's the other end of that social contract is the hard work. And so I'll just give you one example of what we've done. Melissa Blakeman, we support to help us understand access and template management. And one of the things Melissa has done is she's created a purposeful structure to onboarding new physicians and advanced practice clinicians to say, within a certain amount of time, you're going to be 50% full, and within a certain amount of time, you're going to be 100% full. We had never done that before. And, all throughout our regions, people would ramp up at whatever pace they felt was comfortable for them. But what we provided was a structured kind of onboarding ramp up so that the clinicians have felt supported in their ramp up. But because they're ramping up faster, there's much less of an investment required as we bring in a new clinician. And all of that goes to support that non-face-to-face clinical time. So, none of this is really, I think, by chance. It's really been the compilation of a lot of hard work. Our chiefs and our medical directors across JHCP, they're the ones that touch the hearts and minds of their physicians, advanced practice clinicians. And I think that they are the ones setting the tone for it being an organization that at least is trying to create balance and well-being.
I love that so much. That really, they're the meta things we do it as an organizational level, excuse me, and then there are the things that happen in that culture space, and they all work together to create that frontline experience. Just quickly, you mentioned Alice Lee and her work with the art magazine. And I will say that Maracay. Do I have that right?
Meraki.
Meraki. I'm sorry, I have that pronunciation wrong. I know she's also done something pretty neat with our Epic landing page recently. Do you want to comment on that, or would you?
Alice is bless her. She's so committed to doing what she can, and I wish that we can give her more support for what she does. And I try, but what she did is well, we all log into Epic every day, and there is a landing page that we all see, and historically it's been these Epic stock pictures, usually something about their epic farm out there in
The
Wisconsin,
UFOs and cows and
and cows and all kinds of things. But they were always interesting. Like if you logged in the evening, you would see cows jumping over the moon. If you logged in the
yes,
morning, it would be some sort of sunshine over a field. But what was recognized is that we had control over what those landing pages were. And so Alice really started a process of folks across Johns Hopkins Medicine sending in their favorite art to be able to upload those as whatever the JPEG or whatever the technology is to serve as a landing page. And they're all credited to the person who sent the photo. So every day when you log in, you get to see something else. I think the current one is one of the medical research buildings in early spring with the cherry blossoms kind of in the form.
yes.
It's gorgeous. And so that again, just little things. And again, Alice, and I'm also proud that in JHCP, a lot of the work we've done, we've tried to spread to other parts of the organization. So this is not just limited to JHCP. Folks across the enterprise are able to submit their artwork.
Yeah, I have when I'm working in ICU, I see it and I get excited about it. And I'm always interested, like, because she's done a great job of like putting the submitter's name on there and what their institutional affiliation is. So it's really fun to be like, oh, this one came from All Children's, or this one's from Suburban, or this is somebody I know at, whatever, ambulatory practice. It's just really, it's a lovely way to build community. And also we get to go on each other's vacations, so to speak, with some great pictures. It was a picture of Bora Bora, I think, a couple of weeks ago. So it just really another fun thing. I'm hoping too that as we better understand the impacts of some of these interventions, that we'll have more opportunities to share them. I know there's interest. I've had some conversations with colleagues I know who also have Epic about how can we disseminate this work with just the landing page and give people ownership of that. How can we disseminate that outside the organization, which I think is really neat. Maybe, as we close, I would just love to hear your thoughts on sort of the future of, rather than the future of well-being, the future of thriving in delivering healthcare, and I guess where well-being lives in that space.
One of the things thank you for the question, Lee, and again, for all your positive comments. One of the things that I didn't yet mention is the technology and leveraging technology. And probably the greatest source of joy that has occurred over the past few years has been ambient technology for note writing. That has been a life changer to a person. Whoever is taking advantage of this new technology has said that this has really been life changing. They use that word, and that's not something that people say lightly. It's just a great example of everything we've tried to do to reduce the administrative burden. And this, as you know, the ambient technology, I think, is the present and the future. Just having that cell phone there as your most important emerging clinical tool, where it's laid on the table, listening to conversations between patients and clinicians and synthesizing notes, is so powerful. It has invariably, indisputably improved patients' perceptions of their providers listening to them. And by reducing the need to type has, allowed our providers, clinicians in our physicians and advanced practice clinicians to be able to, spend more time making eye contact with their patients. And so, that work, along with the work that Maura McGuire and her team have done to try to improve the way Epic is used within a practice, the way messages are shared, the way refills are handled, so that we teach ourselves to minimize the burden of the electronic medical record. All of that has the opportunity to invest in joy. The future, one of the things that I've tried to do, particularly in primary care, is recognize that the volume of again, time and attention, the volume of patients that we take care of can sometimes be one of the greatest sources of stress. There are emerging models of, particularly in primary care, where we're able to reduce panels. And when we can reduce panel sizes and do that in a way that doesn't necessarily create shortages, and at the same time allows us to pay more time and attention to our patients, we can improve outcomes. I do think that those models are going to be part of our future. Things like direct primary care, leveraging some of our special models like J-Home, home-based primary care, our primary virtual care center, where it's completely remote and we're able to provide remote on-demand care initially for primary care, but now we're hosting that for some School of Medicine specialties. I think that will give, as I mentioned before, that heterogeneity, the opportunity to work in hybrid environments and think differently and act differently. That in and of itself creates a greater sense of well-being, I believe, amongst our clinicians. So we're going to do more and more of that over time.
I love that. Rethinking the work sort of in its entirety, I think is such a fruitful opportunity for how we allow people, that piece of autonomy that's so important, I think, in feeling good about our work, and having those options is fantastic. Well, Steve, I said this already, but I'm just really excited about everything that's happening in JHCP, and excited with all the opportunities to partner with you guys and to share all the amazing work. So thank you so much for being with us today.
Well, I appreciate the opportunity to share what we've done, and again, would like to just really reiterate how important the work is that you've led across Johns Hopkins Medicine in well-being, because we tap into that, and as you and I talked about in our pre-conversation, I send our providers to you on a regular basis to try to get some hints as to how they can manage some of their well-being. So we're incredibly grateful.
Well, thanks again. It's been a great conversation. Signing off for Vital Conversations podcast, this is Lee Doherty-Biddison, your host. Have a great day.
So that's it for today. If you enjoyed what you heard, please share this podcast with a colleague. And as always, we welcome your feedback.
If there are any topics you'd like to hear about, please email us at owb@jhmi.edu.